Hello dear students, my name is Knyazov Igor. Today we discuss the male infertility and sexual function disorders, and we will start with the sexual function. And of course we have to start with the functional anatomy of the penis. So anatomy of the penis is composed of three cylinder structures. It's dorsally present the corpora cavernosa, and under it we have the corpora spongiosa. So corpora spongiosa is a loose connective tissue which surrounds the urethra, and corpora cavernosa. So it's corpora cavernosa is this part which facilitates the process of erection. So let's talk about this in detail. The corpora cavernosa is paired, so it's extensile vascular tissue sheathed by the tunica albuginea. So, and actually this tunica albuginea is very tough, very dense connective tissue. So, and during the vasculature present there, so getting very fulfilled. So that leads to erection, and tunica albuginea gets very tensed due to increasing of volume of this corpora cavernosa, and that's facilitates the erection process. So between these two cylinders are interconnected in males, in human beings. So as here's written that in some species, like in dogs, septum completely separates the corporal bodies. So actually it's necessary to facilitate the diffusion of blood from one to another part. So in case of any organic lesions of corpora cavernosa on one side, so it will be well supplied, even anyway well supplied by shunting of blood from one side to another. So each corpus cavernosum is a conglomeration of vascular sinusoids, larger in the center and smaller in the periphery. Interconnected sinusoids are separated by smooth muscle trabeculas surrounded by elastic fibers, collagen and loose areolar tissue. The structure of the corpus spongiosum in glands is similar to that of the corpora cavernosa, except the sinusoids are larger. Terminal cavernous nerves and helicine arteries of the phallus are intimately associated with the smooth muscle of the corpora. That's during erection, rapid entry of arterial blood to central and peripheral sinusoids enhances oxygen tension and raises pH. So that's how it looks like. Yeah, this is a corpus cavernosum, corpora cavernosa. So here you see this capillaries and connective tissue between them, and here is the interconnected, a little bit interconnected between each other. So the two corpora cavernosa, and under this we have corpora spongiosa. So, and here in this slide we more detail talk about tunica albuginea. So this tunica albuginea is present here, you see, and it has interconnections like adhesions here between different parts to keep integrity. Yeah, because the integrity of the tunica albuginea is it depends on this. We have a successful erection. This micrograph of human tunica albuginea, so you see it's a typical expression of dense connective tissue. So so we have collagen masses which are directed parallelly to each other, and also it contains a lot of elastin. Elastin permits the penis to expand during penile erection. Arterial supplement. So arterial supplement goes through the internal pudendal artery. That's it's a penile arterial supply, and it supplies as well as cavernous body, corpora cavernosa, and also it supplies the corpora spongiosa. So that's why during the erection not only corpora cavernosa is enlarged, but also corpora spongiosa is a little bit enlarged, but not as well because it doesn't contain so deep capillary lining, embedding inside. So venous outflow. Venous outflow is also very important in process of erection. So, and venous outflow goes through the subtunical venous plexus. Subtunical venous plexus, so which collect the blood into the to internal pudendal veins and periprostatic plexus. So, and this passing through the periprostatic plexus is very important for process of erection, because during the erection, so okay, details about process of erection, so we discuss a little later. Hemodynamics and mechanics of erection in the tumor cells. So, so what happens during the erection? Pudendal arterial flow. So you see, we divide this phases, so erection, into different phases. So zero phase is a flaccid phase, so just rest here. First is latent phase. So what happens in latent phase? We have increasement of blood supplyment of penis, arterial supply of penis, but still pressure is pretty low, because we don't have venous compression here yet. So still we have pretty large amount of blood coming to penis in second phase. In second phase, known as tumescent phase. Arterial supplyment a little decreasing here, but venous outflow is decreased. Yeah. And that's why erection is in progress, because still blood coming here, but penis is not so tense yet. And finally, you see that in third phase, when we have plateau of venous outflow, so which is promoted by cavernous nerve, so venous compression is reached some process. What is present? So that's a full erection phase. So this third phase is full erection, and then we have some changes. So when we have a decreasing of venous outflow, but arterial income also decreases to prevent the congestion process. So actually it is congestion, but not so severe, so and that's why arterial inflow so also decreasing. So that's why it will come to the rigid erection. This rigid erection, so that's a main phase in which sexual contact is most successful. Then and then initial detumescence. So that's initial detumescence happens after the ejaculation usually. And so what's happening? So venous compression decreases, and we actually have repeating of this phase 3. So also you see values of blood intake and blood outflow is getting similar to phase 3, and that's initial detumescence happening. Then in phase number 5, in phase in phase number 5, it's initial detumescence happening. So it's a little decreasing of arterial flow going on, and little increasing of venous compression happening. And then gradually you see venous outflow remains and arterial supplyment decreases. Venous outflow also decreases. So that's this will be slow detumescence, and in 7 we have fast detumescence. Okay, you see that in phase 3, 4, and 3 again, so we still have erection. This is sexual intercourse. And all phases from 0 to 2 and from 0 to 2 is the initiation of erection, so that's a process of excitement. And after phase 5 till 7, so it's phases of detumescence. So neuroanatomy and neurophysiology of penile erection. So here we see this is a dorsal nerve, so which is derived from pelvic plexus. So arises the pudendal nerve, so which supplies not only penis, it supplies all the scrotum, it supplies also muscles of perineal muscles. So that's very important in facilitating of erection. So brain centers of orgasm. So it's we have different parts. It's increased activity. It's mesodiencephalic transition zone. It's ventral trigeminal area. So it's activated by opioid. And then increased activity secondary areas. So it's midbrain, lateral, central trigeminal field, tegmental field, the zone inserta. So okay. The cerebellum, so facilitates the emotional processing, and amygdala adjacent entorhinal cortex, so they decrease the activity. Dopamine. Neurotransmitter receptors and functions. So you see here are all the neurotransmitters which are acting in a process of erection. So how it works, how it's aligned. So we don't going to discuss it. It's very deep neurophysiology. So, but just for instance, you should observe it. But physiology of erectile dysfunction. Erectile dysfunction. So what we claim as erectile dysfunction is the inability to attain or maintain an erection sufficient for satisfactory sexual intercourse. So later we name this as impotence. So incidence is very high. So of course at age before 40, only 2% of men can complain to this disorder. But in 65 years, so almost 25% of men they have the erectile dysfunction. So that's why age and erectile dysfunction is very comorbid. So they're actually very closely related. Risk factors. Risk factor conditions commonly associated with erectile dysfunction include poor health status, chronic disease status, vascular metabolic diseases, conditions of the nervous system, hormonal issues, medication use, psychiatric, psychological disorders, substance abuse, and certain socio-demographic factors. So you see, anything which is not healthy, as we claim not healthy, so it might be the risk factor. And first of all, of course, as well, so erection is maintained by process of blood supply. So of course, blood vessel injuries, so like atherosclerotic disorders and diabetes mellitus disorders, like chronic metabolic disease. So they play a very important role in the evolvement of this disorder. So here we have a functional classification of erectile dysfunction. We can claim it's arterial, neurologic, cavernosal, and hormonal. So systemic diseases, they cause arterial, neurologic, and hormonal disorders, and cavernosal also. And drugs affect cavernosal, hormonal, and neurologic status. Yeah, so that's why you see all of them are interrelated. And in the center of everything, so even without these disorders, we have psychological diseases, which also functionally decrease the activity of penis, cause erectile dysfunction. So arterial disorders might be arterial itself or arteriolar. Yeah, so like in metabolic disorder. Neurologic might be sensory, motor, autonomic, neurotransmitter instability. Hormonal status include testicular, pituitary gland, and thyroid gland involvement. And cavernosal, it's pathology of tunicale albuginea, cavernous muscle, gap junction, endothelium, fibroelastic trabecula, and emissary vein pathology. So usually happen due to injury. Classification. We mainly classify it in two ways. It's organic and psychogenic. So let's talk about organic. Organic, it's might be vasculogenic, so it's due to arteriogenic. So when arterial supplement is not okay. Cavernosal, so when backflow of the blood from the penis is disrupted. And mixed, so when both of them are involved. Neurogenic, so when we have neurological lesion, so not psychological, yeah, neurological lesion, so which cause dissatisfying erection. Then anatomic, so anatomic inability to have it. Endocrinologic, so like testosterone level, decreasing of testosterone level, or increasing of prolactin level. And medication induced. So might be some drugs, and we're going to discuss it a little later. So they cause the erectile dysfunction. Might cause erectile dysfunction. And also we have psychogenic factors, and we will discuss about this only here. So because it's more task of a psychologist and a psychiatrist to handle it, but usually psychologists deal with it. It's generalized. It's generalized unresponsiveness, so that's actually patient has no sexual desire, no sexual arousability, and aging-related decline in sexual arousability. So might be just by age they stop having sexual intercourse. Then generalized inhibition, it might be chronic disorder or sexual intimacy. Situational, it might be partner related, performance related, and psychological distress or adjustment related. So for details you can read here. So actually I give you a book, PDF of the book, so you can read about it if it's interesting, but you can claim it's just psychogenic, generalized, and situational. That will be enough for you to know. Endocrinologic. Low serum testosterone. So of course, first of all, it's low serum testosterone. Testosterone is the main male hormone, so and of course it plays a role in formation of sexual desire. Androgens include the growth and development of male reproductive tract and secondary sex characteristics. The effects on libido and sexual behavior, and low serum testosterone supplementation enhances sexual interest, increases erectile response, and linked to improvements in several non-sexual quality of life parameters. So many men with low testosterone levels are asymptomatic. So and in association with insulin resistance, so we can say that which found in type 2 diabetes and metabolic syndrome. So it leads to deposition of visceral fat and androgen deficiency. So androgen deficiency is related to fat deposition. So it's suggested. So it's not confirmed, but we have a relationship between the fat deposition and testosterone level. So it must be somehow testosterone is reduced in fat tissue or just increased body mass. So leads to utilization of this testosterone much faster. Hyperprolactinemia. So that's hyperprolactinemia. So we're going to discuss it in erectile dysfunction and also in male infertility topic. This high level of serum prolactin, so it leads to loss of libido, erectile dysfunction, galactorrhea, gynecomastia, and infertility. So and hyperprolactinemia, so it also decreases the level of serum testosterone, because actually prolactin it's causes inhibition of gonadotropin-related hormone secretion, so in hypothalamus. So you remember this negative feedback reaction. Okay, arteriogenic factors of erectile dysfunction. So it's impaired penile perfusion is a component generalized atherosclerotic process. So you already discussed atherosclerosis process in internal diseases and pathology. So that's why the risk factors. So I guess it's not a question for you. Cardiovascular diseases. So it also includes arteriosclerosis. So how cardiovascular diseases links erectile dysfunction. It's endothelial dysfunction. So that's nitrogen oxide releasing oxidative stress, which is followed by endothelial dysfunction. So of course it impairs the normal function of erection. Smooth muscle defects, so maybe hyperplasia and other contractility due to lack of supplement. Autonomic dysregulation, it's neuropathy and diminished NOS content. Then hormonal disruption, it leads due to lack of supplement, it leads to hypogonadism. And metabolic defects, it's hyperlipidemia, advanced glycation, and products. Okay. Promoted by many experts as an early indicator of systemic endothelial dysfunction, as an indicator for cardiac risk stratification. So that's why symptom of erectile dysfunction, it's a symptom of cardiovascular disorders too. So which changes of structural changes lead to erectile dysfunction? So we already discussed it a little bit, so let's categorize it. Cavernous artery. So when we have increased vascular resistance, narrow lumen, so due to atherosclerotic lesion or any other autoimmune lesion of blood vessels, or might be even infectious lesion, so of cavernous artery, so it increases narrow the lumen of artery, and yeah, resistance is increased. Smooth muscle pathology, so it due to hypertonicity of the smooth muscle cells, decreased smooth muscle content, and alteration of potassium channels and gap junctions. Cavernous tissue, so it might be due to fibrosis, usually secondary collagen deposition due to chronic inflammatory and chronic lack of blood supply lesion, and also it leads to loss of elastin, and the tensibility of cavernous tissue is impaired. And then impaired vena occlusive mechanism. So that's vena occlusion, so is maintained by prostate and also by smooth muscles of veins which are passing through the tunica albuginea. So that's why impaired vena occlusive mechanism, so causing the erectile dysfunction. Endothelium lesion, so impaired endothelium dependent relaxation, so can cause the erectile dysfunction. Then tunica albuginea, it's alteration of elastic and collagen fibers. So actually predominantly of collagen fibers, it leads to elasticity properties changing, and elastic fibers, increase of elastic fibers, it leads to decreasing of toughness of this tunica albuginea, so that's why erection is not stable. And neurotransmitters, it's decreased NMS and ENOS, so endothelial nitric oxide synthase and neuronal nitric oxide synthase, so which secrete the nitric oxide, so which is the main important factor for dilation of blood vessels. Structural defects, of corporal structural defects. It's a vena occlusive dysfunction may result from various pathophysiologic processes, including degenerated tunica changes, fibroelastic structural alterations, insufficient trabecular smooth muscle relaxation, and venous shunts. It's degenerative changes, so due to tissue senescence, diabetes, traumatic injury, so in case of a penile fracture, for example. And they can impair the compression of the subtunical and emissary veins. So, some antihypertensive agents also play a role in erectile dysfunction, and there are some groups of drugs which are playing a role in it. Diuretics, so it causes erectile dysfunction twice as common as placebo. So we don't know exact mechanism of this, but somehow diuretics are playing a role in it. Beta blockers, so it projunctional A2 receptor inhibition. Not 100% of persons who use beta blockers are erectile dysfunction, but it has its confirmed mechanism, and in patients who already have some blood vessel lesions and been given with beta blockers, so they have a higher incidence of erectile dysfunction. Alpha-1 blockers, so in fact decreases erectile dysfunction rate, but may cause alterations of ejaculation. So alpha-2 blocker like tamsulosin, yeah, it's a tamsulosin, so which actually erectile dysfunction is better, but still ejaculation is it leads to retrograde ejaculation. Okay, alpha-2 blockers, they inhibit the central alpha-2 receptors. So angiotensin converting enzyme, unlike beta blockers, it causes possible reduction in erectile dysfunction. So that's why it improves the properties of erection. And angiotensin 2 receptor blockers, because pathophysiological mechanism of these drugs is similar, so it also gives the same result as the angiotensin converting enzyme inhibitors. So let's talk about other drugs. So if thiazide, diuretics, and general beta blockers causing the erectile dysfunction, so we suggest alternatives like angiotensin converting enzyme inhibitors, angiotensin 2 receptor antagonists, and we use selective beta blockers like alpha blockers, calcium channel blockers, so which can be replaced from beta blockers. So that's why if you are not urologist, even you're not a urologist, but you care about the erectile function of your patient, and you should care because it improves the life properties of this patient. So then you can change these drugs to these drugs. Psychotropic effects. Psychotropics drugs, so like antipsychotics, antidepressants, anxiolytics, they can cause erectile dysfunction, but in urine anxiolytic like bupropion and buspirone, so this effect of erectile dysfunction is decreased. Erectile dysfunction is less common. Anti-androgens, of course, anti-androgens, so like androgen receptor antagonists, luteinizing hormone releasing hormone agonists, 5-alpha reductase inhibitors, they are causing decreasing of androgen formation. Of course, they are prescribed in patients who has some, so for example, we have tumors, benign or malignant tumors, and of course it has no alternatives for treatment, so that's why so here we choose between two bad options, so to have erectile dysfunction progression of this disorder, and or opposite, it's we have no tumor, but erectile dysfunction is there. And of course recreational drugs. So recreational drugs like tobacco or alcohol, so in large volume, they cause erectile dysfunction. And tobacco cessation, so of course it improves the normal blood supplement of the corpora cavernosa, and of course tobacco cessation is required. And a large volume of alcohol causes erectile dysfunction, but in moderate amount of alcohol, so it even improves erectile function properties. So okay, that's enough. We talked about erectile dysfunction. We discussed a lot in practical classes. That's why we shift to male infertility. So male infertility affects 15% of couples. So according to World Health Organization. You should understand that previously male infertility was like obscuring, because usually when science was not evolved, so all the blame coming to females, because historically females had only one partner, but males could afford different partners, and that's why no one knows, no one knew, so what is the cause of it. But now, with the improvement of medicine and with the collection of more experience, we figure out that male infertility is also very common condition. So it is on the same level as the female infertility. So because I repeat it again. So previously, in infertility, only females were blamed. So, but it's absolutely unfair. Okay. So which final diagnosis of male infertility? So it's suggested. It's if I'm mistaken, it's USA studies, and I want to pay your attention to this number: idiopathic cases. Idiopathic means we don't know the exact reason. So 32.6% of males, they have idiopathic reasons of male infertility, and only 26.6% they have varicocele. So that's also very common condition. So, but which can be handled just by surgery, very small surgery, and in practice you would see it. So that almost every day we perform 1, 2, 3 varicocele in our clinic. And if we talk about entire Kyrgyzstan, so daily we perform might be hundreds of these surgeries. So that's why varicocele is, this problem is So also we have obstruction of vas deferens usually, so or obstruction on the passage of semen and sperm cells. So it's second common known cause of male infertility. And the rest of this is distributed between normal female factor, cryptorchidism, ejaculatory failure, endocrinological reasons, drug of radiation, genetics, testicular failure, blah 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 blah. So you see a lot of different reasons we have. So read it in details. For optimal characterization of semen, men should be instructed to wait 1 or 2 days after ejaculation to submit a specimen for semen analysis. So actually in Kyrgyzstan we suggest 2 to 3 days of wait after ejaculation. But anyway, so increasing the probability of conception and pregnancy intercourse every day around the time of ovulation is likely the best strategy. Okay, of course you understand that a pregnancy occurred during the time of ovulation, and of course sexual intercourse should be here. And scientists they claim that actually around the time of ovulation should be more sexual intercourses. So, aside from the typical questions regarding medical and surgical history, answers to a number of questions specify related to male reproduction, male sedate, causes of infertility. So you see, remember mnemonic tics, so about male infertility. And you should talk about toxins, ask about toxins, then infections and inflammatory disease, history of infection and inflammatory disease, childhood history, and sexual history. Let's talk about this. Toxicity. So which toxicity might cause the infertility? Is endocrine modulators. So endocrine modulators like idinavir, spironolactone, nilutamide, so bicalutamide, so flutamide. So these drugs they acting on pituitary gland. So and it can secondarily decrease the level of FSH and LH. Inhibit its release, and of course testis cells, so Sertoli cells and Leydig cells are very closely related to these hormones. And intratestical testosterone synthesis is reducing. So you see recreational drugs, so like cigarette smoking and cigarette smoking, yeah, they directly decreases the seminal parameters. So its studies were performed in 1986. And still we have no other results. So, but it's not for everyone. Yeah. So as I said, maybe I said in practical class, Okay, so anyway, so smoking of cigarettes decreases the DNA quality, sperm DNA quality, or decreases the activity of sperm, so and then oxidative stress susceptibility, so is decreased. So that's the role of cigarette smoking. But electronic cigarettes, so we don't have enough studies about it. We don't have long-term studies, but recently studies shown, so short-term studies, they claim there is no effect. So there's no data for negative influence of electronic cigarette use for sperm quality. Antihypertensives. So we will discuss antihypertensives, how they affect blood supplement, and they can they have direct effects on male reproductive function to erectile dysfunction, and also some studies shown that might be mannose-ligand binding receptors prevent sperm from attaching to the zona pellucida. So that's an essential part of the fertilization process. So must be in pairs. So calcium channel blockers impair fertilization. So that's one of reasons. So that's why calcium blockers, like antihypertensives, it has a toxic effect for the fertilization. Antipsychotics. So antipsychotics, it's diminished libido, and also it leads to elevation of prolactin level. So about role of prolactin we discussed a little later, but it's one of the main hormone which causes male infertility. Okay. Opioids. Opioid analgesics, they suppress LH release, so due to suppression of pituitary gland activity and LH is decreased. Okay, antibiotics. So it's most of antibiotics, they have a toxic effect, so as well it has toxic effects to bacteria, so it also has effects on the sperm activity. So and spermatogenesis and sperm activity, so already evolved. Cytotoxic chemotherapeutics, so without any questions, I guess, so chemotherapeutic drugs, they impair the normal cell division, and first of all affecting rapidly dividing cells like spermatocytes and spermatogonia cells, of course. Anti-inflammatory drugs. Anti-inflammatory drugs, they impair the normal synthesis of prostaglandins, and of course, they are linked in formation of semen. Phosphodiesterase inhibitors like sildenafil, so that's so this main treatment of erectile dysfunction. So it's induce a premature acrosome reaction. So it's we have claims that it's induce a premature acrosome reaction. Environmental toxicants like insecticide, pesticide, heavy metal, lead, air pollution. So they suggesting that playing role in decreasing of sperm function. How it's related, so we're not so confident. So maybe it's lower serum free testosterone, and so that's unlikely to say. But and here again, in one study, men consuming locally produced vegetables had lower serum free testosterone, luteinizing hormone, sperm concentration, normal sperm morphology. So that's interesting. And air pollution. Thermal toxicity. Thermal toxicity, so it's first of all related to the venous outflow. So if heat exchange is being changed, so like due to wearing of underwear, so due to wearing of very warm underwear, so it leads to heating of the testes, and also varicocele. So when venous outflow is impaired, so then local temperature in testes is higher than 2 to 4 degrees below core body temperature. So that's impairs the normal synthesis of sperm cells, and that's why healing of varicocele by surgery, so it's one of the main option in treatment. Radiation. Radiation, of course, so without any questions, you understand that lessened by radiation doses to test is 7.5 grays and above, so that's that can cause features of male infertility if we have injury more than 7.5 grays. Of course, it affects the injury of DNA, and that's why due to injury to DNA, it leads to impaired maturation of sperm. Infections and inflammation. Infections. So we're going to discuss these infections in topic. We all discussed the UTI. We discussed the STDs. And all of them, they have effect on inflammation directly in testes, or in vas deferens, or epididymis, or in prostate and seminal vesicles, which and urethra, even urethra, bulbourethral glands, they all of them are affected, and disrupt impairment of one of this function, but usually impairment of few of these functions. Of course, it decreases the normal semen existence. Infrequently encountered infections in the testes may include rubella virus, mumps, Coxsackie virus, B, Neisseria gonorrhea, Trichomoniasis, Ehrlichia coli, rubinosa, Klebsiella, Staphylococcus, Streptococcus species, mumps orchitis, so that's can cause, of course, impairment of normal sperm synthesis. Yeah, and also chronic infections. So it can cause anatomic lesions, which can lead to strictures. It's obstruction, so it's a restriction of normal passage of sperm cells through the vas deferens. Okay, in vitro laboratory experiments demonstrated a negative effect of Escherichia coli on sperm. Majority of bacteria, including Escherichia coli, have limited or no effect on sperm motility in vivo, but in vitro it has. Okay, let's keep it. And childhood diseases. So you have to ask your patient about pediatric surgeries. So which due to cryptorchidism usually might be due to test distortion, history of test distortion. So because test distortion, so we will discuss in childhood pathology of urologic disease. So when we have a torsion of testis and arterial supplement is remained normal, but venous backflow so is very decreased. So it leads to congestion, acute congestion and red infarction of the testis, and it leads to, of course, impairment of testis function. So in the history you have this, so might be testis function is really decreased. Cryptorchidism, it's a congenital disorder. It's when testis is appeared upper in the inguinal canal, so and is not distended. And even if a patient had a history of cryptorchidism in childhood and after surgery decreased, it distended in the scrotum, anyway function is lower. So so here we have the data. So in case of unilateral cryptorchidism, so 96% compared with the control population is normal. So they don't have male infertility, but only 70% of persons with bilateral cryptorchidism they have normal fertile functions. Then testicular dysgenesis hypothesis, so that the point in this, actually genetics also can be included here. The dysgenesis hypothesis that any lesion, so any lesion in genital and urethral tract of males, so it has a subtle, maybe not evidential lesion in histological lesion in testis function. So that can explain the male infertility. Sexual history. So of course, first of all, sexual history. You should ask about erectile dysfunction of this patient, or might be use of some drugs for sexual stimulation. Yeah, so that might be about postures. Yeah, by which they have sex. So how commonly they have sex? Did they follow the menstrual cycle? So have they do sexual intercourse during the ovulation? So that's the sexual history you should ask. Physical examination. Yeah. So what is the physical examination we should perform? Of course, obesity. Yeah, you should check the obesity of the person. So because as we discussed before, so obese person, obese man, they have much less level of testosterone, serum testosterone, so which disproves which decreases the activity of Leydig and Sertoli cells in testes. So. And SHBG, this is sex hormone binding protein, or sex hormone binding globulin. It's typically reduced in obese men, in general ascribed to increased circulating insulin in obesity. Examining of the scrotum. So what we can check during the examination of the scrotum. So first of all, of course, varicocele. yeah, we can suggest it's a hyperplastic changes so for testes. Yeah, so we can evaluate the size of testes. How to evaluate it? So it will be next slide. So also might be absence of the scrotal contents since burst. It's usually due to pityrochidism. And of course reactive hydrocele or tumors might present there, so by which patient didn't mention before might be. But most commonly you can encounter with varicocele. So and varicocele of third stage, so it might be as large to be visible, so large to be visible. So that's yeah, and we already discussed that varicocele can cause the increasing of blood or increasing of temperature in the scrotum, and of course also leading to impaired sperm synthesis. So how to examine the testis size? We check the long axis of the testis is gently grasped between the jaws on the caliper, so this caliper is being used, and measures of 4.6 centimeters or less is associated with spermatogenic impairment. So here caliper, okay, and actually we use volumeters. Yeah, so if we don't use caliper, we use special volumeter. So and you just by physical examination you check the size of the testis, and we have gradation here. If it's lower than this size, so that's a symptom of hypogonadism. Spermatic cord examination. So spermatic cord, as we can see it visually, so in grade 3 varicocele, but in grade 2 and grade 1, so we also can have some effects on the sperm synthesis, so that's why grade 1 palpable only with the patient standing and performing Valsalva maneuver. So that's Valsalva maneuver is when you tangent your diaphragm, so when it's pretending that you defecating, yeah, so that's Valsalva maneuver. So then pressure in veins of abdomen increasing, and it increases in varicose veins of testis. But if we don't do the Valsalva, then the pressure is not elevated, and you have normal size of veins. Then grade 2, which is so we can palpate these veins, and they are palpable but not visible. And in grade 3, varicocele is large even without palpation. So phallus examination. So what we can see the phallus, what we see in phallus, it might be phimosis, meatal displacement, or in case of hypospodia or epispadias, and curvature, penile curvature. So actually phimosis, so all these cases they challenge the process of injection of the sperm into the cervix of uterus. So of course, if ejaculation happens not in a cervix but in the vagina, of course chances that this semen will fertilize so is very low.